Hello and welcome to today's webinar, Psoriasis and Skin of Color. My name is Bev Bromfield and I'll be your moderator for today's presentation. Before we start, I'd like to go over a few items so you know how to participate in today's event. We've taken a screenshot of the attendee interface. You should see something that looks like this on your computer desktop in the upper right corner. You've joined this presentation using your computer's audio system by default. This means if you hear music through your computer, you should be able to hear the presentation. If you prefer to join over the telephone, select Use Telephone in the audio pane and the dial-in information will be displayed. You'll have the opportunity to submit questions today by typing into the questions pane on the control panel. You can send your questions in at any time during the presentation. We'll collect these and address as many as possible during the Q&A session with today's speaker, dermatologist Dr. Tiffany Mayo. Before I provide information about the foundation, I'd like to acknowledge and thank our sponsors, Amgen, Janssen Pharmaceutical Companies of Johnson & Johnson, and UCB for their support of today's webinar. This webinar is also supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $300,226,934, with 8% funded by CDC and HHS, and 8,750 and 92% funded by non-government sources. The contents are those of the author and do not necessarily represent the official views of, nor an endorsement by CDC, HHS, or the U.S. government. Since some of you may be new to the foundation, here's a little background about who we are, our mission, and what we do. For over 50 years, the National Psoriasis Foundation has served more than 8 million individuals in the U.S. living with psoriasis and psoriatic arthritis. Founded from a tiny classified newspaper ad in Portland, Oregon, the NPF mission is to drive efforts to cure psoriatic disease and improve the efforts of those affected. After completing one of the most ambitious strategic plans in its history, the National Psoriasis Foundation launched a new 5-year strategic plan in July 2019. With a continued focus on a life free of psoriatic disease and its burdens, NPF remains committed to finding a cure for psoriasis and psoriatic arthritis while supporting individuals to live longer and healthier lives. Over 5 years, NPF will focus on achieving 3 goals: lead collaborative transformational research in psoriatic disease, increase the lifespan and health of individuals living with psoriatic disease, secure the human, technological, and financial resources necessary to achieve NPS mission-related goals. By viewing today's program, you've taken a step towards expanding your knowledge about psoriasis and psoriatic arthritis, moving towards a better understanding of what it means to live with psoriatic disease. A few of the many ways that NPF supports the goal of leading collaborative transformational research includes, to date, NPF has funded close to $30 million in grants and fellowships. That includes almost $3 million in grant and fellowship funding announced last July. NPF grant mechanisms support all stages of research and careers. Our efforts focus on areas of unmet need and are often conducted in partnership with research stakeholders with whom we collaborate. In addition to funding outside grants and fellowships, the NPF also leads research initiatives such as the Psoriasis Prevention Initiative and the Psoriatic Arthritis Diagnostic Test Grant. The Psoriasis Prevention Initiative was developed at the recommendation of the Psoriasis Prevention Initiative Steering Committee, who urged a definition of prevention to better guide proposal development, and that's how it expanded to include disease relapse and comorbidities. Now in phase 2 of the funding cycle, NPF plans to invest $6.5 million over 5 years in this effort. The second initiative is the Psoriatic Arthritis Diagnostic Test Grant, which aims to develop a diagnostic test for psoriatic arthritis. Now in its 3rd year of funding, this grant funds projects that will significantly reduce the time between onset of symptoms and a diagnosis. This is important because we know as little as 6 months of delay between onset of symptoms of psoriatic arthritis and start of treatment can lead to permanent joint damage. This slide highlights 4 NPF research efforts that you can be part of. Launched in 2015, the NPF Cori Vitas National Psoriasis Patient Registry, formerly known as CORONA, is the largest independent observational registry of psoriasis patients in the U.S. This registry collects and studies patient health information, allowing researchers to compare the safety and effectiveness of psoriasis treatments, better understand conditions that are related to psoriasis, and explore the history of the disease. There are currently more than 12,700 patients enrolled at more than 521 sites across the country. Your dermatologist may be enrolled as an NPF Corrivitas National Psoriasis Patient Registry site. If you're not sure if they are, ask. If they're not, encourage them to join. Citizen Scientist is a platform where you as a patient answer survey questions, which you and researchers can analyze for trends and new insights. Citizen Scientist is currently being revitalized for greater community benefit. The LIGHT study is a real-world research study that compares the effectiveness of home versus office-based UVB phototherapy treatment of psoriasis. Entry criteria for the study are simple. You must be age 12 or older, have plaque or guttate psoriasis, and be a candidate for office or home phototherapy. There's no washout of topical, oral, or biologic medications, and the study is designed to easily incorporate into routine patient care. It is also unique because it includes equal representation of all skin phototypes. The NPF annual survey is a data collection effort the Foundation has conducted for 2 decades. This research conducted each fall provides insight into the lived experience of individuals with psoriasis, including quality of life and unmet needs. If you're contacted about this annual survey, we would appreciate you sharing your experiences with us. To achieve the mission's goals as mentioned, please support our mission through donations or by participating in virtual or live team NPF events such as Stamp Out Psoriasis Walk or cycle events. You can learn more at psoriasis.org/donate or teamnpf.org. On behalf of the National Psoriasis Foundation, thank you for attending today's webinar, where you'll learn more about how to identify clinical features of psoriasis and skin of color, challenges and pitfalls that could impact diagnosing psoriasis in skin of color, treatment choices and tips to help care for skin of color with psoriasis, resources to help learn more about psoriasis and psoriatic arthritis. Now I'd like to introduce you to our speaker, dermatologist Dr. Tiffany Mayo. Dr. Mayo is a board-certified dermatologist and assistant professor of dermatology at the School of Medicine, University of Alabama at Birmingham. Additionally, she has a clinical practice with cosmetic dermatology and laser clinic at the Whitaker Clinic at UAB Medicine. Her clinical interests include skin of color, hair, and scalp disorders. Dr. Mayo is the director of the Dermatology Clinical Research Unit and an associate scientist with the Center for Clinical and Translational Science. Dr. Mayo is also the course director of medical student education, School of Medicine at the University of Alabama at Birmingham. It's my pleasure to welcome Dr. Tiffany Mayo, who will present today's webinar, Psoriasis and Skin of Color. Please welcome Dr. Mayo.
Thank you. Thank you. These are my disclosures, but I will say none of them are necessarily relevant to today's talk, but some of the medications, if you all ask specific questions about them, may be related to some of the clinical research that I've participated in the past. So let's just jump right in since we've already gone over the objectives. So let's start with just what is psoriasis? And I know many of you, you already know what it is. It's part of your lived experience. But psoriasis is an immune-mediated condition that we know is characterized by these sharply demarcated erythematous, or what we call red or pink is what the definition is, plaques. But we know that red or pink may not be exactly what you see in skin of color. And so since this is kind of the highlight of our talk tonight, we're going to dive a little bit into how psoriasis may appear differently in skin of color that can affect why providers or physicians or nurse practitioners have difficulty sometimes diagnosing it, and even why we as patients may think that it's sometimes something different. So there are several different types of psoriasis. There is plaque psoriasis, which is thought to be the most common type of psoriasis, but there are other forms, guttate psoriasis, guttate meaning drop-like. So there's typically smaller little areas of involvement. There's inverse psoriasis, which we'll talk about a little bit later. And this is psoriasis that occurs mostly in body folds, like under the breast, under the arms, the abdomen folds, such as that. And this type does not involve a lot of scale. There's erythrodermic psoriasis, and then there's pustular variant. So I wanted to also talk about systemic disease, because psoriasis, a lot of patients, a lot of physicians who are not dermatologists may think of psoriasis as only a skin disorder, but we know that it is not. That's why diagnosis in skin of color patients, even if it involves a small localized area, this is still important because patients may be at risk for other systemic, complications that could be associated or related to their psoriasis. So psoriatic arthritis is one of them. And then there's increased risk, we now know, for metabolic syndrome and cardiovascular disease. So the prevalence of psoriasis, definitely more prevalent in Caucasians. So there's been some studies looking at this, and these numbers will vary across studies, but we know that it's more prevalent in Caucasians and probably about 3.6% seen there. The next most prevalent would be in the Asian population, then Hispanic, followed by Black or African American. But the thing to note about these numbers is that it is underreported in skin of color patients. So I would say the prevalence probably is a little bit beyond 3 to 3.6% in Caucasians, but as far as skin of color patients, we don't know. That's the truth. We do know that psoriasis occurs in skin of color patients, probably a little bit more prevalent than what is reported, and we know that it most often presents with severe disease. Now, why is this? Is it because of delayed diagnosis? Possibly. Is it because there is something related to genetics in patients who are skin of color with psoriasis? We don't know that. So let's talk about genetics a little bit. There's a positive family history. Some thinking 35 to 90% of patients with psoriasis. So there have been genome-wide association studies looking at genes possibly associated with psoriasis. HLA-CW6 is the gene that has been most closely associated with psoriasis. This is a gene that's important in our immune system, and it's the one that if you look up genetics of psoriasis, you're going to see that this could be associated. But I'd like to highlight that the majority of studies looking at the genetics of psoriasis, the majority of these have included patients of European ancestry. There's been maybe a couple that have included Asian ancestry, but other than that, there's been very limited skin of color involvement in these genome-wide associations. So when it comes to the genetics of psoriasis and skin of color patients, we just don't know. I'll say interestingly, we mentioned this HLA-CW6. When I was a resident, that was the gene that you needed to know that's associated with psoriasis. But the truth of the matter is that this gene is more prevalent in patients of African descent than it is in patients of Caucasian descent. But we know that Caucasians get psoriasis more prevalent than Black patients. And so there is some thought that even with these genetic susceptibility genes, they probably are more related in specific groups. So for instance, we may say HLA-CW6 means that someone may have a higher likelihood of developing psoriasis if they are Caucasian, whereas HLA-B52, not CW6, may be prevalent in some other ethnic group for their likelihood of developing psoriasis. So there's a lot more work to be done there. And, this also kind of highlights that we do need involvement of skin of color patients with psoriasis in some of these studies so that we can have a clearer understanding of what the true genetics is of psoriasis in all different ethnicities, because we already can see some differences here. So let's jump into clinical findings in skin of color. It's just not going to look like the textbook case. So on that first slide, I showed you that classic erythematous plaque with overlying scale. Well, to start off, erythematous just may not be what we see. We like the term violaceous. Because that's more of a purplish gray that you see in skin of color patients instead of erythema. So you may see violaceous or hyperpigmented plaques in skin of color patients. You're also going to see a lot more post-inflammatory hyperpigmentation or hypopigmentation. Now that just means dark spots related to inflammation or even light spots related to inflammations, as you can see in some of our patients we've seen at UAB in that top panel. We also know that skin of color patients with psoriasis tend to have or present with thicker plaques. Now, we don't know if this is because they do tend to present with more severe disease or if there's something related to why these plaques would be thicker in patients in skin of color patients. Some of the things to watch out for. So I talked to our residents and even other physicians and physician assistants, nurse practitioners, our nurses. We talk about what are the things that patients may do when they're not sure what their, quote unquote rash is. And so we talk about things like, some of my nurses say the first thing I do is put Neosporin on it. And then some of my patients will tell me, well, I tried tea tree oil and that didn't work. So we tend to do things to try to fix our rashes before we know what they are. So I always warn that whenever someone is presenting to the dermatologist with a rash, just watch out for overlying eczema type rashes or contact dermatitis, because the chance is that the patient has already tried to treat their condition at home. Now, from a patient perspective, it just muddies the water when you have a rash that you've treated with something that you may not know you're sensitive to, and now you have a new rash on top of your old rash. And so it can just make it a little bit more difficult to diagnose. So make sure when you're presenting to dermatologists to just let them know all of the things that you have tried at home to treat this, so that they can be aware of the things that are common to cause contact dermatitis. But there are some other diagnoses that are common that may look like psoriasis. So some of them are lichen planus, another inflammatory condition, discoid lupus, which is definitely common in Black patients, sarcoidosis, also common in Black patients, and cutaneous T-cell lymphoma is another one. So if a provider is concerned about a rash and they're not certain that it is psoriasis, a biopsy is the most helpful thing. So we don't often biopsy psoriasis, honestly, because it's one of those what we call slam dunk diagnoses. You know it when you see it, but not in skin of color. And so I always tell patients, if you've been diagnosed with a rash and it's not getting better, then a biopsy, or asking if it's a primary care physician that's helping to manage, asking for a referral to dermatology, or even if it's a dermatologist, because not all dermatologists may be seeing as many rashes in different skin types as they do in Caucasian patients. And so they may, they may misdiagnose initially, and that's not uncommon. So a biopsy can be very helpful. But when it all boils down to it, we talk about the things that truly matter when it comes to evaluating the skin and evaluating psoriasis. So one thing to check for is morphology, which is what does it look like? So even though, for instance, if you look at this gentleman's back here, even though he doesn't have the erythematous plaque that we characterize as being associated with psoriasis, he has a very well demarcated, meaning very clean lines and edges, and he has these plaques on his back in the same distribution that you would see psoriasis. It may not look initially like psoriasis, but if you took away the color of it, it would be psoriasis to most dermatologists. So the morphology is the same. Other things that you could look for, especially if it's a patient and they're not sure if they have psoriasis, and their doctor may say, oh, well, I think you have eczema or some other type of rash, is there are some other things that could be a sign that it's psoriasis. So one of them is geographic tongue, so changes on the tongue. Nail pitting is another, and then joint pain, joint involvement. All of these are things that can help a clinician as well as a patient be a part of the team in helping to diagnose psoriasis, because sometimes it truly is a team effort to arrive at an accurate diagnosis with cutaneous findings in skin of color patients. So these are just some of those clues. So you can see here, I was trying to find an image that represented joint pain. So not everyone, this is very obvious joint pain in this patient with psoriatic arthritis, but definitely pain in the fingers, pain in the toes. Those are things that are concerning to us for psoriatic arthritis, especially if the patient has other findings that may represent psoriasis. Also, nail pitting. So you can see this patient has numerous. Most often, I don't see this many nail pits, especially in mild to moderate psoriasis, but this is basically an example of what nail pitting is. And then geographic tongue is where the tongue has multiple or a few, as in this patient, erythematous plaques with kind of this raised border or outline. So these are just some of the other things we look for as clues to help diagnose psoriasis. So let's talk a little bit about site-specific psoriasis. Scalp psoriasis. I really want to talk about this. So scalp psoriasis is common regardless of ethnicity, but some studies have shown it to be more common in skin of color, particularly our Asian patients. And so it's a very highly prevalent phenotype, even though plaque psoriasis is talked about most and is thought to represent probably over 90% of the psoriasis that we see. You can see here in this study, scalp psoriasis actually was quite prevalent, almost at around 50 or so percent of the psoriasis in this study. If you look at this graph here, they're looking at the different phenotypes of psoriasis that we're seeing. So because seborrheic dermatitis or dandruff is highly prevalent in patients of African descent, diagnosing scalp psoriasis can be very challenging. And sometimes we as physicians we won't make a decision. We'll call it SIBO psoriasis, which means a combination of seborrheic dermatitis and psoriasis. It means it doesn't quite fit all of the features of psoriasis, but it's a little bit more than what we typically see with seborrheic dermatitis. So let's give it this term, SIBO psoriasis. So even though this is a diagnosis, I really caution clinicians from just diagnosing a patient with this without following up. Because, as we mentioned before, there are some systemic associations with psoriasis that you don't see with seborrheic dermatitis. Seborrheic dermatitis is dandruff, and though it can create itching and mild inflammation, it does not affect the joint. It's not associated with metabolic syndrome and some of these other things, cardiovascular risk, that we are starting to see are associated with psoriasis. So it could be a case where scalp psoriasis is the only clinical presentation that a physician can see of the psoriasis. And so if a patient has scalp psoriasis and they're just diagnosed with SIBO psoriasis and treated with a topical steroid and maybe dandruff shampoo and told, I'll see you when I see you, then that's not adequate management for this patient. So definitely if you've been diagnosed with SIBO psoriasis, I definitely encourage you to continue to follow up with your dermatologist just to make sure there are no new findings, and if they are, letting your dermatologist know so that they can be managing you adequately. The next thing is inverse psoriasis. So inverse psoriasis is that psoriasis we mentioned that occurs in areas of body folds, like under the breast, under the arms, and in body folds on the abdomen and such. This is often misdiagnosed as yeast, what we call intertrigo. But this is seen in 21 to 30% of psoriasis patients. And I can even tell you, in one of my skin of color patients, I treated her for about 4 months thinking that she had yeast under the breast area until it dawned on me, why is she not responding? If this was yeast, she should be responding. It's psoriasis. So those are the kinds of things that are common to happen. I mean, it even happened to me in a patient, and it could happen to any dermatologist. And so as a patient, you are as much a part of the treatment team as a physician. And so when patients do not respond, it's time to either consider another diagnosis or do a biopsy. So inverse psoriasis can be difficult to distinguish from intertrigo. And just like scalp psoriasis with seborrheic dermatitis, yeast and these conditions occur in the same location. So yeah, a patient with psoriasis on the scalp probably also has dandruff. And yes, a patient with inverse psoriasis can also have yeast. So they can have both of these things. And the yeast is a little bit inflammatory, which could possibly be making the psoriasis on the scalp and under the breast or under the arms worse. And so treating both of these at the same time is a very common way to manage this. And here in this table, it's just showing the likelihood of having two different phenotypes together. So a patient with scalp and inverse psoriasis, that may be seen in about 15% of patients, which could both be misdiagnosed. So that's just something to consider if you're someone who thinks you may have a history of psoriasis, or you know someone who has presented with these symptoms but has not responded to therapy, that it really could be psoriasis. These are some of my patients with scalp psoriasis, and I just wanted to highlight all of these patients were thought to have seborrheic dermatitis or dandruff. Yeah, they probably have a little bit of dandruff, but there are a few things that stand out. So for this lady here, if this lady was a lighter skin type, this would be bright red, and no one would miss this diagnosis. They would say, oh, absolutely, this is scalp psoriasis, or this is some condition other than just dandruff. But because she's skin of color, the erythema does not look as bright and alerting or alarming. And so this patient had been misdiagnosed as having seborrheic dermatitis and was just treated with an anti-yeast shampoo. Also, same for this patient. So this was a patient that I actually saw virtually, and I thought that, either this is scalp psoriasis, or she could have, if she's someone who gets chemical relaxers or gets her hair treated with a color treatment, that's something else that can cause an inflammatory condition or contact dermatitis on the scalp. But when I saw her in clinic, she had these thick plaques around her ears that you can see here, and I could see the erythema a little bit better, and so a diagnosis of scalp psoriasis was made. So dermoscopy or trichoscopy is the use of a tool called a dermatoscope to take a closer look at different things. We often use it for pigmented lesions, but I also like using it for inflammatory lesions because it really can help distinguish between things that may be very similar. So here I'm looking at one of my patients here. You can see this patient here to the far left. She has scalp psoriasis. And when I look at that, this actually isn't her image, but when I look at scalp psoriasis on dermoscopy, the scale, I can see this background erythema, first of all. But the scale in scalp psoriasis is kind of fine and white. Whereas if you look at this patient here on the far right, you can see this patient has not a lot of redness or erythema to her scalp, but you see this thick scale. And so when I took a closer look at her scalp, you see this scale looks more waxy, more yellow and waxy, kind of more greasy scale. This is more characteristic of seborrheic dermatitis. So even without a biopsy, I could tell from just looking at dermoscopy that this patient here likely has more seborrheic dermatitis and that this patient has psoriasis if I wasn't sure clinically. Either way, a biopsy could have been used to help with the diagnosis. All right, so I want to get into some of the little nuanced things. So I want to talk about Kepler phenomenon. So this is the appearance of new lesions due to trauma. So Kepler phenomenon happens in other inflammatory conditions as well, but it is known to happen in psoriasis. So when we think about some cultural practices that may cause mild trauma, even cultural healing practices that may cause mild trauma, for patients with psoriasis who perform these practices, it can result in worsening of their psoriasis. And this may be something that baffles the clinician because they're not used to seeing it in a certain distribution, or they may be wondering, well, why isn't the patient getting better with the therapy? But if they're causing mild trauma to the area that's being treated, particularly such as the scalp, then you may see refractory disease. So this is a picture of me when I was in college, and this is my grandmother, and I had come home from college. And so scalp scratching, in my family especially, but in many patients of African descent, is very common because, as I mentioned, seborrheic dermatitis is common. We don't wash our hair every day. We often use oils that can worsen seborrheic dermatitis, and so it's so common that uplifting the scale with a fine-tooth comb called scratching the scalp is almost like a practice. So much of a practice that it becomes more of a bonding experience. So you can see it looks like I'm telling my grandmother a really good story about something that happened at college. And you can see her, she's listening as I'm scratching her scalp. And so even if there was no scale there, the point is now this is more of a cultural practice than it is something that's actually helping her scalp. But I show this picture because I thought of it for someone who has scalp psoriasis. They actually do have scale. And so the practice of scratching the scalp would be worsening their psoriasis, oftentimes even regardless of if they would have been on adequate treatment because of kepler phenomenon. So this is important when you think of like religious practices or someone who may wear a religious covering that has pins that may scratch the scalp, or participate in activities such as cupping or something that may cause mild trauma. So you may see psoriasis in an odd distribution due to associated trauma due to the kepler phenomenon. Now, this other thing, I just added this, honestly. I just wanted to give an opportunity to show my children. So greasing. Greasing, I mentioned before that you may not, in Skin of Color, you may not see things the way that they are described in the textbook. And so particularly with Skin of Color, I think greasing is common because there is a concern for xerosis and scale. No one wants to look dull. No one wants to look ashy, which shows up a lot more on Skin of Color. So in my household, it is very common before my kids walk out the door to let me grease your face. It actually has become quite popular. I can't remember what it's called now in the media. Slugging, that's what it's called. But I think it's been very common in many cultural practices to apply grease, on the face and other areas, especially for children. And so these are my kids. The daycare teachers always tease that my children are all greased up, and so that's greasing. And then this is my daughter just really taking it to the next level with greasing. You can see her and making sure that she's all greased up. Mommy was not too happy about this situation, as you can imagine. But my point in showing this is to say that you may have less scale than anticipated for the amount of plaque that someone has, especially if they're applying a lot of grease. So if you're thinking about the scalp, if you're thinking about the rest of the body, if the patient is very sensitive to the fact that the scale is there, they may be trying to mask it or covering it by greasing or some other practice that can help get rid of the scale. All right, let's get to psoriasis affecting other areas that are a little bit challenging, and the beard comes into play here. So perioral psoriasis is actually one of the least reported locations of facial psoriasis. So facial psoriasis does occur, and the more common would be the forehead, for instance. That's way more common. So around the mouth, for whatever reason, has not been reported as much, but it can occur. And this becomes a problem for patients who have beards. And I say patients because even though we think of our male patients as having beards, in some cultures, women having hair on their face have a little bit more hair, I guess I should say, than others. And so shaving or threading or waxing or having to groom that area is not uncommon. And so this can be a problem for psoriasis. And so thinking about ways to manage psoriasis in the beard area or any hair-bearing area on the face is going to be important, because in Skin of Color, you're also going to be worried about associated hyperpigmentation in this area. So being quite aggressive initially is important. So some of the tips that I just wanted to include here for the face and hair-bearing areas is, one, the wash. So a salicylic acid wash tends to be helpful to get rid of some of the scale and help, especially if it's someone who prefers to wear a long beard, like a male wearing a longer beard. It may be helpful to use that sort of wash to help with the scale and plaque. And then also when treating it, choosing a vehicle that can penetrate through the hair if the person prefers to wear a beard is helpful. So a liquid, foam, a thin lotion vehicle will be helpful. So notifying, sometimes the provider doesn't think of this. So so, for instance, if it's a male or if it's a female provider who has never had to deal with a beard, then she may not think about, oh, I need to make sure that the patient can actually get the medication to the affected area of the skin. The other thing is avoiding trauma from repeated shaving passes. So remember, keplerization. So psoriasis gets worse in areas of low-grade trauma or areas of trauma, period. And so shaving is a form of low-grade trauma and exfoliation to the skin. And so multiple passes can, in fact, worsen psoriasis in this area. So avoiding trauma from going over the same area multiple times, causing more excessive damage to the skin in that area, can make the psoriasis refractory there. All right, so therapies. So there are multiple ways to approach psoriasis. I know psoriasis has the research in psoriasis has just exploded over the past few years, and it is awesome. It's amazing to have so many options to offer to patients. So there's topical therapies, there's intralesional steroids, there's phototherapy, there's biologics, and then there's pills. There's other types of systemic therapies that patients can take. I think one of the things that is the most concerning for me as a provider as I think about skin of color patients, one is delayed diagnosis. So assuming that the patient does not have psoriasis because psoriasis isn't thought of, it's not on people's radar in skin of color patients. And so patients presenting with more severe disease. So by the time a patient whose skin of color presents with psoriasis, it may be moderate to severe, which is going to require more than a topical therapy. So then my next concern is treatment hesitancy in skin of color patients. There is more treatment hesitancy. There's less involvement in clinical trials for drugs in skin of color patients with psoriasis. So we mentioned previously, before I started, there were trials, there were registries, there were surveys. I do encourage you all to participate in those if you have psoriasis, to help better our understanding of psoriasis, to help better our understanding of the genetics and how it may affect skin of color patients differently, but to also participate in clinical trials if your dermatologist feel like you are a good candidate, and also if the current treatment isn't working for you or what's currently available. That's another good reason to at least learn more about clinical trials for therapies. But there are multiple therapies that we have. So topical therapies and intralesional steroids are more, I guess, appropriate for patients with mild disease. When you start to get into moderate disease, that's when phototherapy or light therapy, narrowband UVB, eczema, those are some of the therapies that have been shown to be quite helpful. Intralesional steroids, I'll say, a really good treatment option if there are a few plaques that aren't responding to treatment, such as in the scalp or a few plaques on the body. Intralesional steroids can be a really good therapy. We don't give systemic steroids like prednisone. We don't give that for psoriasis because we know psoriasis will flare even worse once someone tapers off of those. So we don't give that. But once the patient is in the moderate to severe category, really thinking about things that can provide more coverage for therapy is important. So the phototherapy, the biologics, and other systemic therapies like methotrexate, we talk about acitretin, apremilast, cyclosporin. Those are some of the oral forms of medication that can be helpful. So then what's next? Normally, when you talk about treatment, that's the end of the presentation. Like, okay, this is what you have, this is how you treat it. But we know with skin of color, that is not the end. And that's one of the most important parts of the talk, I feel like, when we're talking with providers or patients with skin of color or providers who are not used to treating skin of color. There is a next step, dyspigmentation management. So the first thing for helping prevent dyspigmentation as much as possible with psoriasis is early diagnosis and appropriate management. So early diagnosis is that's the patient and the physician. Okay, early diagnosis is not something that the physician can take complete control over. The patient sometimes has to assist the physician by coming in to see the doctor, letting them know if they're not responding to therapy. Because even though it's horrible sometimes, the delay in treatment and the amount of work that a patient has to do to convince the doctor that they're not responding, but it's important that it happens. And so understanding that the patient is just as involved in this team of diagnosing conditions adequately, especially when their skin of color, is very important. So the earlier we can diagnose psoriasis, the better. And then appropriate treatment. Sometimes topical therapies are not appropriate depending on the severity of psoriasis. And so if psoriasis is moderate to severe, it is likely going to need more than topical therapy. So having a good conversation, having a good understanding of what's happening in your body, the effects of psoriasis, and balancing that with the risk profile or concerns about, for instance, a biologic medication are very important. So appropriate therapy can help prevent some of the dyspigmentation that we see, because hopefully the disease won't be as severe. Other things, so retinoid. So that is a topical type of therapy. So tretinoin, for instance, is a retinoid that can help when used in combination with a topical steroid to decrease dyspigmentation. Kligman's formula is a formula that combines a skin lightening cream with a topical steroid and a retinoid. So we know topical steroids are helpful. We know retinoids are helpful to treat psoriasis, and combining that with a skin lightening cream like hydroquinone can offset some of the dyspigmentation if it's hyper, meaning more pigmentation, so dark spots. Other things, chemical peels. Chemical peels are a little risky because if they're too aggressive and lead to an actual burn, then that can lead to Kepler phenomenon and worsening of the psoriasis. So it would have to be done by a board-certified dermatologist who's adequately evaluating to make sure the appropriate strength of the chemical peel. But that could be a decent therapy for hyperpigmentation related to psoriasis. And then some over-the-counter skin lightening creams. So hydroquinone is no longer available over the counter, but it used to be. Currently, it's only available in prescription form. Also, azelaic acid. This is available over the counter. It can be used twice a day on hyperpigmented areas. Arbutin, niacinamide. These are all things that are available over the counter that can help speed up the recovery from dark spots. So without treatment, dark spots can last up to a year. Or more, or sometimes dark spots can even be, I don't like using the word permanent, but can really last several years. So using some of these over-the-counter products at the same time as treating the psoriasis, as long as they're not irritating, can be helpful. And I think that is my last slide, and so we'll move on to Q&A.
Great. Thank you, Dr. Mayo, for providing such an amazing and informative presentation about managing psoriasis and skin of color. As you mentioned, it's now time for our Q&A portion of this webinar. Dr. Mayo, our first question is, what are the current challenges with treating psoriasis and skin of color? Are there any challenges with topicals specifically?
So topicals are a great option for managing psoriasis with skin of color. So there are several different topicals. There's topical steroids that are helpful. There's vitamin D analogs that are helpful for treating psoriasis. There's topical retinoids that we mentioned, and there are topical calcineurin inhibitors like tacrolimus or pimecrolimus. So these things are all helpful in treating psoriasis. The challenge becomes when the psoriasis is covering a larger body surface area to the point that it's difficult for the patient to manage putting the topicals on. So again, we get to understanding appropriate therapy for the amount of disease. And then if a patient has joint disease and even a small amount of psoriasis, making sure that they are adequately managed with systemic therapy that can help calm down the inflammation in the joint to prevent further joint damage. So when it comes to difficulties with therapy, I think we are we're kind of in the golden age of therapies for psoriasis right now, thankfully. But that doesn't mean that every patient is responding 100% to even the best therapies that we have. And so understanding why that may be, making sure that the patients are on the appropriate therapy for their disease severity, whether that be body surface area or joint involvement or other systemic inflammation. And also making sure the patient understands the medication that they're on, making sure to counsel the patient who may be hesitant about certain medications, giving them time to think about these things. And if the patient isn't willing to consider the medication that a provider is offering to them, coming up with the next appropriate step. So those are just some of the challenges.
Great, thank you. And another question, what can you apply to thinner skin areas on the back of the hands? Not the palm, but the back side of the hand.
Mm-hmm. So even though the back of the hand is thinner than the palm, topical steroids are still an appropriate choice here. But if it's, for instance, like the thickness of the skin can vary with age, can vary just with, several different factors. You do have the topical calcineurin inhibitors, the vitamin D analogs that don't cause thinning of the skin. And so those would be things that could be appropriate. Even retinoids. So even though retinoids cause increased cell turnover and kind of dryness when they're used on the face, when they're used on the body, they can cause a little bit of irritation, but that doesn't necessarily mean they're causing thinning of normal skin. It actually can be helpful to normal skin. So combining a topical steroid with a retinoid or using some of those non-steroid options if there's true concern about thin skin or what we call atrophy of the skin is a good option.
And should people of color be as worried about exposing their bare skin to the sun if it helps alleviate psoriasis symptoms?
So that's a tricky question for a dermatologist. So we talked about light therapy and how it can be helpful in psoriasis. It's true that even the sun can be helpful in psoriasis. It's also true that even though skin of color is not as at risk of developing skin cancers as lighter skin, as Caucasian skin, and so there is not that huge concern about basal cells and squamous cells. Like melanomas can occur in anyone. Basal cells can occur in anyone. Squamous cells can occur in anyone. So the amount of sun that's needed, for instance, it is not an excessive amount that will cause a sunburn, for instance, even 10 minutes. When we talk about patients who have vitamin D deficiency, one of their big concerns is, well, should I use sunscreen? I don't think I should if I have vitamin D deficiency. I think I need more sun exposure. Well, yes, you need more sun exposure, but that means 10 minutes a day. That doesn't mean spending hours out in the sun. So I'm not as concerned about the skin cancer, for instance, risk of spending 10 minutes in the sun. I do prefer, though, a more selective treatment of narrowband UVB therapy for the phototherapy of choice as a light therapy for psoriasis. One thing I didn't mention is that light therapy is a great treatment option. It can cause hyperpigmentation, though. So it can cause just like tanning of the normal skin. So making sure that patients understand that their normal skin will get darker and the dark plaques will get darker as well initially from light therapy. And that can be a very normal thing, but light therapy is very safe. And so if a patient has other comorbidities that would make a systemic therapy, not a good option, light therapy is a good option. It's just understanding that just like with the sun, everything gets a little bit darker.
Okay, that's good to know. And you referenced shaving earlier. So could the razor bumps be confused with psoriasis in men?
So razor bumps, so we're talking here about pseudofolliculitis barbae or PFB. It could be, but not usually, because pseudofolliculitis barbae typically occurs around the hair follicles, and it may look like just folliculitis or inflammation in the hair follicle in some patients, but often in patients with coarser hair type, it actually forms these firm bumps around the follicle due to ingrown hairs. And that just looks very different, especially to a dermatologist's eye, than a psoriasis plaque does. But if a patient has a lot of psoriasis on their face, which is not as likely, honestly, in the beard area, but it could happen. Then it could potentially be could be misinterpreted as PFB, or the PFB could be misinterpreted as psoriasis. The good news is that I would use the same treatment because retinoids help both of them and topical steroids help both of those things. So I would try to treat two things at once just to make sure I'm not missing something.
And why do you think Black patients may be more hesitant about treatment or to be part of a clinical trial?
Well, there are several reasons. I don't know if we have that kind of time. Right? We know the history of clinical trials, the history of research, even the history of medicine. Minority patients for a long time, there's been a lot of history related to things not being truthful, related to taking advantage of certain populations without their consent. I mean, there's just several stories in history. And so I am a Tuskegee University grad, and most people know about the Tuskegee syphilis study. And you're talking about populations of people whose grandparents may have been very aware of the Tuskegee syphilis study. And so there's a lot of hesitancy even still carried on, especially in certain areas. I'm in the South, and so especially in certain areas, that hesitancy is part of, the culture, and it's part of the experience that certain cultures have had with medicine, with physicians, and with research. So I'm the director of clinical trials, and so one of the things that I am very passionate about is about educating physicians about why this may be, because some younger physicians who may not necessarily be as aware of the history may not understand this, but also educating patients about what clinical trials are, that they're not being used as guinea pigs, the understanding the consent process, understanding that this is not a commitment and they are in full control of their participation at any given time. So I do support clinical trials, and I definitely support diverse involvement in clinical trials because that is how we see which medications work well. Is there something different about certain populations that we need to consider? And unfortunately, up to this point, most clinical trials have included mostly Caucasian patients. So there are so many reasons for hesitancy, but I hope that a lot of industry, a lot of organizations are starting to understand that and are trying to reach back out to the community to help people understand what research is today.
Great, terrific response. And I have another comment. This was an awesome seminar. I have had psoriasis for over 50 years and I have never heard of skin lightening agents for the skin. I have discoloration over 50% of my body. Is it too late for me to start using a skin lightening agent after so many years of not doing anything?
So it can be tricky because often when you've had chronic inflammation, it's not just dark spots. So in dermatology, dark spots are much easier to treat than light spots in the sense that there are agents that can help lighten the skin, those things that I mentioned, but there's nothing that can help put pigment back in the same distribution that it previously was. And so when you have a mix of light spots and dark spots, especially covering large areas, I would be hesitant about applying a direct skin lightening agent. I would probably prefer something like a retinoid that is not necessarily meant to lighten the skin. It increases the cell turnover and can hopefully help to even things out a bit in that way. So it depends on the type of dyspigmentation, but it seems like this patient mentioned dark spots. So skin lightening agents, they're not a home run either. They can just help. So at the same time as I'm addressing psoriasis, I'm thinking of adding things that can help decrease dyspigmentation. But there will be dyspigmentation. There will be dyspigmentation. It's just a matter of how much. Because in skin of color, any type of inflammatory condition is going to leave a footprint of dyspigmentation behind. And so just picking something to help manage that is important, but it doesn't mean that it would have prevented you from ever having the dyspigmentation that you currently have. I don't think it's too late, but I would be hesitant to be aggressive because, again, you don't want to cause trauma and irritation to the skin that can lead to Kepler phenomenon and and new psoriasis or worsening or spreading psoriasis, I would choose something more gentle, like for instance, azelaic acid. Pick a few test areas so that because these things can be expensive even over the counter. So pick a few test areas, use it for about three to 6 months and see if you're noticing improvement, and then decide from there. It's always a good idea, especially in skin of color, to pick a test area and see how you do before you're using things on large body surface areas.
And one last question. How do you manage hypopigmentation when it occurs post-topical steroids?
That's a good question. So usually after discontinuing the use of the steroid, over the next 3 to 6 months, hypopigmentation will normalize if it was from the topical steroid. Now, hypopigmentation from an inflammatory process, like for instance, if the hypopigmentation was truly from the psoriasis itself, it can take a little bit longer, but typically just discontinuation of the topical steroid will allow the skin to then normalize with its usual pigment.
Great. Well, thank you, Dr. Mayo, for taking time to answer the many questions we received and for sharing your knowledge about the nuances of managing psoriasis and skin of color. This was truly an amazing webinar. Thank you.
Thank you.
The Patient Navigation Center is the world's first personalized support center for people impacted by psoriatic disease. If you still have questions, would like additional information about treatment options, need help finding a physician, or are having issues with accessing treatments, contact our Patient Navigation Center by phone or email as indicated on the screen. You can also contact the Navigation Center to ask about receiving a free psoriasis skincare e-kit and skin of color fact sheet, or connect with others who have psoriatic disease through the one-to-one program by calling 800-723-9166, option 1, or send a request to education@psoriasis.org. In addition to this webinar, you can continue to learn about psoriasis and psoriatic arthritis through NPS podcast series Soundbites, which is available through Apple Podcasts, Google Play, Ghana, Spotify, iHeartRadio, Amazon Music, or a feed service of your choice. You can also access podcasts at the website listed here. You can learn more about types of psoriasis by listening to National Psoriasis Foundation Medical Board member Dr. G. Michael Lewitt in episode number 142. Or if you need tips on managing scalp psoriasis, hear doctoral prepared board certified family nurse practitioner Tirsa Cortorlo in episode 154. Thank you again to our sponsors, Amgen, Janssen Pharmaceutical Companies of Johnson & Johnson, and UCB for their support of today's webinar. This webinar is also supported by the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services as part of a financial assistance award totaling $300,026,934, with 8% funded by CDC and HSS, and $8,750 and 92% funded by non-government sources. Contents of those of the author and not necessarily represent the official views of, nor an endorsement by CDC, HSS, or the U.S. government. Please take the survey via the link you receive after viewing today's webinar to provide feedback about the presentation and content. Tell us what you think. We value and appreciate your comments. And finally, you can catch this webinar and other presentations in our webinar archive at psoriasis.org/watch-and-listen. This concludes our presentation. Thank you for your time and for joining us to view psoriasis and skin of color.